All right. Good afternoon, everybody. Can we start with a word of prayer? All right. Dear Jesus, thank you for this opportunity to come together, to be with folks that we can commune with, and maybe we can learn a little bit about medicine and a little bit about who you are and what you plan for our lives. Thank you for all the blessings that you give to us, those that we know about and those that we don't. Amen. All right. My name is Olen Netteburg. This is my wife, Danae, and we have been missionary physicians to Chad, Africa for the last almost 12 years now. And this is a presentation about gynecology. I am an emergency physician, and I married a gynecologist because I hate gynecology. So I can call her and say, I have a female between the ages of 15 and 45, and I don't want to touch her. So, dear, do you mind coming to see her?
Do we have any gynecologists in the...
Yeah.
Yes.
My patient may have a sprained ankle, but if she's between 15 and 45, it's clearly a GYN problem. All right, so my wife does vesicovaginal fistula repair, and so that's kind of what we decided we would talk about today and how we can witness through this specific surgical intervention. Just FYI, when we do take a picture of patients, we let them know, is it okay if we use this picture to motivate and educate and inspire other people? Mostly going to be in America, but maybe other places, and they're always very enthusiastic to say yes. Rarely they're not, and when they aren't, we just don't take their picture so their picture doesn't get mixed up with others. So all of these people are given permission for their stories and their pictures to be shared. I can start with the Bible verse, Isaiah 64:6, but we are all as an unclean thing, and all our righteousnesses are as filthy rags, and we all do fade as a leaf, and our iniquities, like the wind, have taken us away. Curious thing, I am not a Hebrew scholar. I never went to seminary, but the filthy rags thing is actually, those are menstrual rags, is the Hebrew version of that, and it got cleaned up in translation. But we're not actually talking about menstruation issues with vesicovaginal fistulas, but it's all in that GYN, I don't care about it, refer it to my wife category.
I do care about it.
So a little bit about Chad. I'm a numbers geek, statistics. I love those things. So things kind of register in my head when I hear about them in numbers. We first went to Chad in 2009, and these are old statistics. They have improved since then. But when we first went, the maternal mortality rate was approaching 2%, meaning 1 in 50 pregnancies, the mother will die. And based on the number of babies an average Chadian woman has, 1 in 11 Chadian women were dying from an obstetric complication. And just very sobering numbers. The government was proud that they had gotten the cesarean mortality rate down to 30%. 30% of C-sections dying on the table. When we first got there, there was a very small number of physicians in the country. The government invested heavily in getting people to medical schools developed in the country and sending them off to other countries for training. We have a lot of physicians in the country now. They are not specialty trained. But the typical story was you finished medical school today, and tomorrow the government will send you off to a district where you're the only physician for a couple 100,000 people, and you're expected to do C-sections. And there are no anesthesiologists. There is a nurse there that knows how to give some ketamine IV, and that's your anesthesia. So the mortality rates could be because of untrained, inexperienced general practitioners doing surgery. Nothing against general practitioners doing surgery, but usually those people have experience before they're doing things solo. Or it could be anesthesia complications. We have seen a lot of death from, I don't know about a lot, but we've at least seen some death from anesthesia complications as well. All very sad, all very sobering, almost all of it preventable. Neonatal mortality rate, 12.5%. 1 in 8 newborns dies during the newborn period at birth. As an aside, those that do survive, 21% die before the age of 5. More than 1 in 5 Chadian babies die before they're 5 years old. Again, these are old numbers. Things have gotten better in the last 12, 13 years, but still, if not the bottom of health indicators, near the bottom. Just a couple years ago, I don't know what it was recently, but just a couple years ago, Chad was again at the top of the maternal mortality list worldwide. It's a huge delay in obstetrical care. Chad is actually the size of like 3 Californias. It's a big country. No infrastructure. There's one paved road in the country, and the dirt roads are better than the paved road. It's very infrastructure poor. Things like emergency medical services, ambulances, those don't exist. And culturally, when you have a baby, who here's a mother? All right. Culturally, when you are having a baby, the one in charge of your delivery is your mother-in-law. I don't know what your relationship is with your mother-in-law, but I know that wouldn't have gone over well with my wife and my mother.
I didn't want anybody there.
And my mother was actually an OB nurse, but the mother-in-law is the one who is kind of dictating the terms of delivery. When the mother-in-law fails, she will call in a skilled birth attendant. And the skilled birth attendant is a very loose definition. The majority of these people will be illiterate, but they have been trained culturally to be the person in their village and their neighborhood helping deliver babies. When that individual fails at delivering a baby, they will then send the patient to a health center, which might be in that village, it might be in a neighboring village. The health center will be staffed by somebody who's referred to as a nurse, but may or may not have any nursing education, may or may not actually have a high school diploma. When that person fails, then they find a motorcycle or an ox cart or just a cart they can push the woman in, which is probably half the time how women arrive. And they will push the woman for 10, 20 kilometers, maybe more, to the hospital where she can actually then have her baby. So the delay is always going to be several hours. It is very often and frequently several days that the woman has been in labor before she comes to the hospital. Very often the baby is dead before then. And my wife is a huge believer in the vagina and vaginal births and avoiding C-sections for dead babies at almost any cost. You do what, maybe 1 or 2 a year, C-sections for dead babies? Almost never.
If the uterus is ruptured, then you have to do it. But
Right.
the key is to decide if the uterus is ruptured or not.
But in all of these delays, what have I got? Okay, so in all of these delays, well, we'll get to the anatomy of things later. For the non-gynecologists such as myself. Typical chatty, so just an idea of how far behind Chad is in terms of catching up. And we are catching up, but we're still behind a lot of the world. 45% of women have a baby before they turn 18 in Chad. And yeah, they do these, the WHO has these questionnaires where they ask all these not random questions, but questions to people of different gender and of different age groups in various countries. One of the questions that they ask is it okay for a husband to beat his wife? And in Chad, a majority of the women, ages 15 to 24, believe it is acceptable for a man to beat his wife if she doesn't cook well, if she doesn't clean well, if she doesn't take care of the children, and if she doesn't have sex when and how he wants it to happen. So it's very, very challenging to be a female. One year it was named the worst country in the world to be a woman. It's very, very challenging. I know there are a lot of countries out there that are tough, but Chad is among those that are very challenging. This is a typical ambulance that's parked out in front of our hospital. This is actually a good ride to the hospital. It's a very, very, very underdeveloped country. So a little pathophysiology of a fistula. Labor starts, and that uterus is a super strong muscle, and it squeezes the baby down to try to get it out of the birth canal. Usually it's going to be head down. And as that head goes down into the pelvis, that super strong uterus is squeezing. There's the delay with the mother-in-law, the traditional birth attendant, the health center, then finally the hospital. And that can be hours to days of delay. And as that head is mashed down in the pelvis, it's going to be compressing all that tissue, preventing blood flow and circulation to that tissue until that tissue dies, necrosis, sloughs off after delivery, assuming that the woman survives all that process. And in the healing process, you can heal then with a hole, a tract, connecting a communication then between either the bladder and it can go anywhere from the bladder to the vagina. You've seen a couple from the urethra to the vagina. You've seen some from bladder to uterus.
Yeah, we repair
bladder
those.
to cervix as well. And I don't think we've
Everybody
seen...
give Olen a round of applause for the whole GYN
This is an
system.
ER doctor talking right now.
Yes.
Yeah. There's an ER doctor in the back who's
He's helping
feeling
me
my
with
pain
my
right
talk.
now. Have we seen a rectovaginal fistula from
Yes.
childbirth delays?
Yes.
Okay, so there's I've been told there's a rectum back here behind somewhere, and you can even have a fistula created back there as well. The pathosociology, I'm not sure if that's a word or not, I may have just made it up, but there is a pathophysiology and a pathosociology between these. So a woman survives this horrible disease, this horrible childbirth, this traumatic, both physically and emotionally, childbirth. Her baby is almost always, but not always, but almost always going to be dead at this point. And she now has that tract open between the bladder and the vagina. And you have kidneys up here. I'm an ER doctor, so whatever the CT says, I just believe it. But there are kidneys that are...
We don't have CTs in Chad.
Yeah, we don't have those in Chad. CT stands for cut where we are. If you really want to see inside, you just have to cut. So the kidneys are always making urine, right? And they're going down these ureters down into the bladder, and you've got this lovely sphincter down here. But if you have a tract, a fistula going back to the vagina, that sphincter doesn't do anything. As soon as the urine hits the bladder, it's going out that path of least resistance into the vagina. The vagina can't hold anything. It goes out and is running down the leg. So a woman sits down for a minute. When she stands up, there's a pool behind her. As she's walking, it's running down her leg. She's leaving a trail of drops behind her. So she smells of urine. It's a disease that you can't really hide. You can put all the claws down there, but they're going to saturate pretty quickly. And it's pretty bad. The husband usually not always. We have had some husbands that have stuck with their wives through it. More often than not, probably most of the time, the husband will leave her. And I know 0 Chadians who have given their daughter to a man to be married who have not received a dowry. Every Chadian bride that I know of has been bought. And it comes with a money-back guarantee. So if she is now not able to give more children or has this chronic disease, the man can take her back to her family and get her his money back. The family then has very bad feelings because the money they got and spent they have to return. They now have this woman, and a woman's value is significantly decreased in China if she's no longer producing babies or unable to care for babies. And so it's really a challenging situation where this woman is often no longer loved and wanted in her husband's house, in her parents' house. And this has happened where women have come to us after being found outside of their village in a mud hut in the rice field, somewhere starving to death, very emaciated and cachectic. By the time somebody finds them, knows of us, knows of Danae, able to operate on them, and brings them to the hospital. Unfortunately, this is a situation that's happened multiple times. So our goal today is to prepare everybody to be able to surgically correct the most complicated of surgical fistulae, operating in a muffler with concrete or absent tissue, without the benefits of general anesthesia or trained assistance. Pretty much if you sutured up a finger, you're ready to do this. So that's not really what we're going for. So we've talked about kind of the pathology of these fistulas. We're going to spend a little bit talking about what happens at our hospital in very rural Chad. And when I say rural, our region of 1 million people has no electrical grid and has no public water. That's the kind of rural that we're in. We'd like to maybe be able to comprehend the differences between medical mission work in a global setting and what daily practice in America might be like, and discuss if there are means to apply these principles in daily American practice. I'm almost done talking, then I'm going to turn it over to my wife who has some stories. And I think at the end we should have some time to chit-chat and discuss. Usually your questions are more interesting than anything that I can say. Who's been outside of America? I think that's pretty much going to be everybody. Who's been to Africa? Who's been to Chad? Yeah? That's awesome. I'm so sorry to hear that. Yeah. When were you in Chad?
Would have been 2014 with James Appel. He had left Béré and gone to...
Mundu. You were in Mundu. Okay, the big city. Yeah. Yeah, lots and lots and lots of... malaria is, our number one disease that we deal with. you have a little bit of an idea of what our lack of infrastructure and things are like. The literacy rate is about 10%. Literacy defined as you can read well enough that you could use that as part of your job. 85% of Chad is agrarian. You grow what you eat. Chad is right there in the middle of Africa, kind of the edge of the Sahara, the edge of the Sahel Desert. You could draw this line right across there, and the northern two-thirds is very much so desert, and down here is more what you think of typical sub-Saharan Africa. And where we are is we're down in the southwest corner of the country right there. This is our team. This is our hospital staff. We're at about 60, 70, I think, employees now at our hospital, 25 to 30 nurses. This is Doctors Eric and Megan Tricarton. He is now doing pediatric surgery fellowship in Colorado.
Andrew.
What did I say?
Eric.
I don't know where that came from. That's Andrew. This is Stacy Davenport. She's a family practitioner who also did a year of OB fellowship. And Sarah is not there. Anyway, there's another physician, Sarah Belinsky, who actually presented at Amen. I guess would have been 2019 maybe. But yeah, that is at least part of our team, the ones that showed up. So typically when a woman comes to the hospital, you can make the diagnosis when you bring her into the room, because she's going to be standing up from a pool of urine, trailing a pool of urine behind her, and you can smell her. And I don't have to examine her. I can say, dear, there's a woman here between the ages of 15 and 45. Can you just take care of it? And Danae will want to know where it's coming from and all that before she agrees to operate. They are often, like I said, very malnourished and neglected, or depressed and just not eating because they're going through a severe depression, or there's just a lot of malnutrition in Chad. But doing surgery, doing an elective case on somebody who's already malnourished, we try to avoid that whenever we can. And these are elective cases almost always, so they can be delayed to kind of optimize their nutrition. We did have an active inpatient nutrition center a couple years ago, and sometimes these women would spend a month down there kind of getting as healthy as they could before surgery. Pre-op labs, talk to the family and the patient, let them know kind of what's going to happen, what their expectations should be. You know, we're not going to operate and you go home the same day. Be ready to actually stay in the hospital for a while. Danae used to pay for all these surgeries herself. We've had some very generous people help us out, so that covers the expenses. Everything we do is completely free for these women. Their food, everything. We get the pre-op labs that she wants. Danae does whatever voodoo that she does in the operating room to close the hole. I've kind of understood that you kind of cut everything back to make it look the same, close the bladder, close the vagina. Maybe if you get some healthy layers.
He's ready to operate.
I know exactly how to call in a gynecology consult. And then the cool part is, what?
Go ahead.
No, you want to take over? All right.
Let's have that later.
All right. Yeah, you have that later. Yeah, go ahead. All right, so now some specific stories of people that Danae has operated on and what the post-op course looks like.
He does let me talk sometimes. Actually, I prefer to be in the operating room and seeing patients, but I'm happy to share these stories because they're just amazing, and I think you'll find that too. Let's see if I can get this clicker to work. This is a story about Louise, and she is the one in the middle, and that is her daughter on the right. The person on the left is actually our guard, so imagine how scary that must be for a woman who comes to the hospital, and we didn't speak her language, so he had to translate for us her problems. But, you know, they're so tired of having this problem that they're happy to have somebody translate that they don't even know. And age is kind of a relative factor in Chad, as you will see. People don't really know their age, so they'll come in for an infertility consult, and they'll be 25, and, you know, they've been trying for 20 years to have children. I'm like, wait, let's add this up again.
And their son who came with them is 35.
Yeah, so anyways, it's fine. It's just not everybody's strong suit. Nothing against Chadians. It's just the village people, they don't have an education. So age, they think, how old am I? They must be older, so they're instantly 40. I'm 43, so I'm like, no, I think you're older than me.
Most people are born... Most people's identification says they're born January 1st, 1940, or January 1st, 1950, or January 1st, 1960. There's a lot of birthdays celebrated on January 1st.
Louise came in, I don't really know her age, but she has an older daughter, and the GYNs in the group will notice that she's had 3 children. One of them is alive. There's just a lot of death in Chad. As we mentioned in the statistics earlier, there's just a lot of death. And we see that. A lot of the babies I deliver are passed away already. So it's just a very difficult place to live. And my first week there, I did 6 deliveries, my first week in 2010. 1 live baby. I had never experienced that in residency. Nothing prepared me for it. And having lived there almost 12 years now, we just have seen a lot of death. So she's had her fistula for depuis. That means since forever, basically. So that's just a word people say, like, well, I've had it for a long time. So we estimated she had her fistula for about 35 years. And she is just the cutest lady. She was so happy. I wanted to talk to you about how we restore people physically. So Olen suggested this a little bit as he talked about it, and he's ready to do surgery, I think. So they present with total urinary incontinence. So that means, as he already described, you're constantly leaking urine. You also don't drink very much, so you're dehydrated, because if you drink, you're just going to leak it out. So you're constantly leaking urine. I do a history and physical. The reason I put these labs up here and everything, in America, you would probably have a CT urogram, lots of different labs, a huge workup. I see the woman, I put her up in stirrups, I do a physical exam, sometimes it's hard to see the hole, sometimes it's like a 4-centimeter hole. So I put a Foley in, I backfill them with, usually I just use water now. That's really sad, but you have to use something sterile in America. But where we live, it's, we're just trying to do an exam to tell if they have a hole or not. And then we backfill their bladder, and you can see with your eyes if there is urine leaking out or liquid. We pay for their labs pre-op. These women do not have any money, and so word has gotten around that if they come and show up, they'll get everything paid for free. The fistula part, the fistula surgery part, we have a lot of surgeries in Chad, so we're not just doing fistula surgery. Fistula surgery is less than 1% of the cases that we do. We do a lot of GYN, a lot of general surgery stuff too. So it's nice when we can group them all together and kind of get all of the women together. And we do something called a fistula camp. So we have about 20 patients usually, or 10 to 20, if we can group them together. And then they all come together and we do a week of fistula surgery. If you have any questions about the actual surgery so we can complete the objective, I'm happy to share with you afterwards. But for most non-GYNs, you just have to know that you can repair it surgically. That's the main thing. They usually stay about 2 to 3 weeks with the Foley catheter in. I don't send them home because if they had a complication, the Foley would get blocked, and if they were home, it would break the surgery. Basically, if your bladder is full, it's going to break the part that we just repaired. So I have them stay at the hospital, so if they have any problems, they can call me and wake me at 2 in the morning to go deblock their catheter. This is Louise. This is after she went through her surgery. This is our pre-op area and our post-op area, and that is her daughter with her. And this is her when she was dry. So it's just an incredibly rewarding surgery to do because it's something simple that we can do to change their life. And when I say change your life, you go, and we'll explain that a little bit later, but you go from being a complete outcast to then being restored. This is Rebecca. She actually lived really close to our hospital.
Can you go back a slide? Should point out, you see all those pink dresses? All of those pink dresses, except for the man and Danae, they all had fistulas, and they were all operated on at the same time or in the same week, and they're all getting to go home and start new lives.
This is Rebecca. We've been doing fistula surgery for, 5, 6, 7 years. The first one I saw, I remember I was like, we weren't trained for this in residency, because in America we don't have them because we don't have really real delay in obstetrical care. But when I saw one, I was like, oh, this is what they talked about in the books, and then I have to look at it in a book and actually learn how to do it. I didn't have somebody teaching me. I actually learned from reading a book. But she lived less than 10 miles away from the hospital, and she has had her fistula for 10 years. So she's in around 40. She's had 9 children, and I want you to notice that she has lost 5 children. So she has 4 children, but she has lost 5. Just the amount, people don't really like to hear our stories anymore because sometimes they can be very depressing because there's just a lot of death. But it's just the reality, and it's a world that's outside of this world I know there's death in this country too, but it's just a different world that you should be aware of. So because I had a group coming over to do a video to try and bring awareness to what's going on in Chad, we made a radio announcement because I was looking for more fistula women. And we had about 20 that week. And these were 20 women that lived pretty close to the hospital that would not have been repaired if we wouldn't have put that radio announcement out. So it was just amazing that she lived less than 10 miles away and she'd had this for 10 years. And she did not know that it could be repaired with surgery. And that is her in her new dress. A lot of these women, as I mentioned, they have terrible histories with their losses. As Olen mentioned too, in the village, they're outcasts, and so they have a lot of mental health, which we're focusing more on in this country. We don't really get to deal with that as much where we live because we're so busy dealing with the physical that we often don't have as much time to talk to people as we would like. However, when we do the camps together and we have about 20 women with the same problem, they can all talk to each other and they know that they're not alone. So it's really great for them to be able to connect with each other.
Can you go back a few slides? One more? Oh, sorry, one more. So there you see her neighbors, the other women sitting on the ground. If you see, they have Foley catheters coming out as well. And they're all in the same boat, hanging out there, all hoping to be healed shoulder to shoulder.
So I don't just do fistula repair. I also do obstetrical care, which it's another lecture, I think. But just a lot of terrible histories. And like, for instance, last year, I know I induced a woman who was on her 5th or 6th baby. All of the other one had been near-term demises. And first time she had a live, happy baby. And I was so happy, the induction process, because they're not on a continuous monitor, is always a little bit scary, but you're just monitoring their labor. And if you can get them early enough, hopefully this baby will be alive. And but I just wanted to mention the picture you see is for losses. So if a woman comes in and she has a loss, we don't have much to offer. A lot of times we can't even communicate with them because they're speaking in a different language. We communicate in French. I don't know if we mentioned that or not, and Arabic. So the official languages of Chad are French and Arabic. But there's over 200? Over 100 local tribal languages. We encounter at least 15 languages every day. So it gets pretty exciting when you're trying to explain Kegels, for instance. So trying to get your...
A lot of charades, which are always fun in gynecology.
Or, a woman's coming in and I'm trying to figure out, what happened. I'm like, did you have fluid? Or, I just do a lot of charades. So it gets interesting. But this is one. It's a picture of Jesus' second coming, Nathan Green, little postcards. And my friend Becca is a doula in America, and I used to talk to her all the time about how sad it was to deliver all these demises. And so we talked about making grief kits, and she helped me with one of the first purchases that I got of these, and we gave the baby footprints along with the Nathan Green postcard. And we can't offer much, but we can pray with a woman, we can give them the postcard, and I always see it when I give it to the patient, and I explain to them, I'm discharging them. I'm like, here's what we have from the hospital, and I'll show them the little picture. There's an angel handing their baby to the mom, and I always see it in their eyes. They're just so happy for that hope, because we all have that hope, but a lot of people haven't heard. Another woman I want to tell you about is Helen. She actually had her fistula for 10 or 11 years. She is a believer, and her husband is a pastor. But one thing is she couldn't read. So, even though she was a pastor's wife and she was in the church, she didn't have a way to read the Bible. So we offer this. She's the second one from the left. Her name is Helen. So we offer something called God Pods, and they're audio Bibles that are solar rechargeable. And they're a really great way. So all of my fistula patients that come in, they're waiting around for surgery until I can get time to operate on them. So some of them wait, several weeks, or I'll have them go home and pay for their transportation and then come back when we're actually having a camp. Or sometimes I'll fit them into the schedule. So every morning we have hospital worship, and so they're literally camped on the hospital compound. It's not like there's a hotel they can go to. They're staying outside. Usually it's not rainy season when they're around. So we do have a television in our kind of waiting area. You can see, I think, this is our waiting area. Where's the pointer? And there's a television up there. So we have morning worship up here, and then the patients come in here and sit outside so that they can be a part of it. Sometimes you'll see patients like over here, like kind of listening. And I love it when we usually translate it into so it's from French and then into the local language, and then sometimes also into Arabic. So you'll have people across the street listening to it. So it's a way to witness.
You also got the TV there.
Oh, and yeah, the TV in the middle too. So we also play the Jesus movie, and it's in many different languages if you're ever going overseas and you have that. It's a really great resource. So I wanted something that women and kids could read the Bible without being able to read. And so years ago, we were like, let's make a picture Bible. So I had little kids drawing me pictures, and they just weren't good enough quality. And then I found an organization called My Bible First, and they make a picture Bible. It's in English, but I saw that they had translated it into French for our friend who lived down the street from us. And so I found different Bibles in the local languages, and I wrote them out. And this one's in non-juré. And she actually printed them for me in the different languages. So it's another resource. If you're going on a mission trip, you can have picture Bibles that will be in their local language. So it just has like a verse that a man could read that might be able to actually be literate. And then the box is the God Pods. They're the audio Bibles that are solar rechargeable. And that's what one of them looks like. And people don't have anything to do. Like sometimes some of my patients, they'll be in the hospital for a month or so with, a chronic wound or something, and they'll have this God Pod that we'll be able to give them, and that's what they do all day is listen to it, and they love it. It has songs on it. It has a lot of different things that you can put on it, and not just the Bible. And this is actually Louise, and that's her with one of her picture Bibles, and we're having a celebration at the end when we celebrated the women getting their new dresses. The spiritual restoration, we talked a little bit about the picture Bibles and the God Pods, but we also pray before our surgery and on wards, and it definitely works. Especially, I wanted to talk about some of the most difficult patients are the ones you pray for the most, and you guys know that if you're dealing with difficult patients. You just want to heal them or you just want to fix things, and you can't always do that. They're the ones you spend the most time thinking about. Most of my patients that have this problem are the ones that couldn't get to the hospital in the first time. So their family might be the most poor, or they might not have transportation to the hospital, so they're never going to come because they couldn't get there in the first place, which is why they had this problem, because of lack of care or delayed care. And then at the market, they can't get a job because they smell, because nobody wants to be around them. So, they really have it bad off. It's really just amazing to see the lives that they've lived. Some of these women, I'm coming up on I just had my 25th high school reunion, and a lot of these women will have had it for 20 plus years, and you're like, wow, all that time since I graduated from high school, they've had this problem, and they've been dealing with it every day at the market. And these are the lucky ones, the ones that didn't die from childbirth. This is Falmata. She is a patient that's her first baby. Her second baby was actually delivered at our hospital when I was gone, and she had a uterine rupture, which is when your uterus completely tears in two. So a lot of times the baby will be floating in your abdomen, already passed away. And this is when they usually call me. The normal deliveries, the nurses deliver, but they usually call me when there's something wrong. And, 24 to 36 hours of being completely dilated and ready to deliver, and then you can't deliver, something's going to give, and it's when the uterus ruptures is when they finally have less pain. So she came to us with a uterine rupture. She ended up getting a tubal ligation and then a fistula. So her husband was like, you're of no good to me anymore. So he left her, and she's a single mom now with nothing to do. Thankfully, she came back to us, and we were able to fix her fistula. And however, she didn't have, so even though I'm saying like your husband left you, you don't have a job, you can't have kids, I don't actually believe that is a woman's worth. This is just what it happens to be there. Obviously, I don't believe that, so I don't want you to think that. But this is just what it happens to be in Chad. It's very sad, and somehow you just have to support them, and you have to even get on the man's side to support him helping her, even though you may not agree with everything he's doing, because in the end, you're still helping the woman. So because she came to us, she's just a joy to be around, and we ended up working with her, and she was close to the hospital, and she has helped me on several of my other fistula camps. So she came and helped provide food for the other ladies, and she also helped talk to them and tell them, it's going to be okay. A lot of them, they don't speak the same language. They're scared. They're coming in. They're like, do they know what they're doing? Is this gonna be okay? And so when you have healed fistula patients come around and they're like, it's going to be okay. This is how it works. This is what's going to happen. It gives a lot of support to the other women. And also, one of the other volunteers is paying for her son now to go to our church school. The arrow is pointing out Falmata. She is not in the outfit that everybody else is because she has already been through this, so she was in a previous camp. But she's there to support the other women.
Isn't she Muslim?
She's undecided, but she did grow up Muslim. She has a Muslim name. But
her son is currently in our church school.
Yep. Yeah. So another thing that we do for them is we provide a new dress for them. And the Bible verse I like is the one that we're dealing with that one that we have this week, is that I have come that they might have life, that they might have it more abundantly. And for me, when we give them a new dress, it's not just fixing their surgery, or it's not just fixing their fistula, it's not just helping them go home, it's giving them extra. It's like that extra little bit of something that says, we love you and we want to see you succeed and we're so happy for you. And it's just a really fun celebration. I wish you all could be there. So this is one of my women, this is some of our women that are picking out fabric. In the beginning, we didn't have a big group, so we had maybe 4 that I would do at a time, and so I would just have them pick out their fabric individually. Now we have a few of them, they kind of come and pick it out with me. This is the first big group that we did. I did not instantly become a fistula surgeon expert. I have learned a lot over the years through books and through what didn't work and what worked. And I had several women that had urethras that were obliterated. So because the baby's head was sitting down on the urethra where you pee from, it was gone. And these are real. So I tried to repair these in the beginning, and then I realized, it's really hard. With fistula surgery, you need to get it right the first time. Otherwise, it's very difficult to repair. So I wrote to many different. I had this book that's called Practically. What is it called? It's a very. I'll get you the name later, but it's a book that shows how to do fistula repair. And I wrote to the author, Dr. Browning, and I was like, hey, he's from the UK. I was like, do you think you could come to Chad? I was writing all these different people, like, who can come to Chad? And they referred me to a Chadian surgeon that lives out in Abashe, which is like 2 days away, that had gone to Nigeria and done 50 fistula repairs, and then he was now the expert. So I wrote him, and he came out to me, and he actually helped me with my first group. They're supported by several different fistula organizations, but he helped me. I learned a lot from him, And then since then, he's been busy doing other things, so I continued on without him. But I really did learn a lot from him on how to make every fistula repair kind of look the same so that it was easier to repair. But we had a good time. We had 28 that first time he came out. And this was in 2019, I think it was. Right before I went on vacation, I was like, I need pictures of everybody before I go on vacation. But this is the women in their new dresses. You can see I'm encouraging them to drink water. They all have their God pods and their picture Bibles, and they're all very happy. And the woman on in the front row, second to the right, like, she looks like she's 90. I don't know, but I don't actually know her age, but she had it for a long time.
Did you have medical clearance before you operated on her?
Her name was Agnes. Thankfully, we do things under spinal, so it's not quite as dangerous as general anesthesia. Thankfully and unthankfully sometimes.
There's an anesthesiologist in the back shaking her head.
Hey, you just try and go quick. Do you want to take over from here? So I actually have a nurse that, his name is Jonathan. He works, I don't know who asked the question. Sorry, I was looking. Oh, okay, yeah. His name is Jonathan, and usually I'm doing it last minute because I've been operating, and I'm like, oh man, there's patients going home. I got to get this picture. And so usually I pay him a little bit extra, but he works in the market as his side job. He's one of our pediatric nurses, and he also is a tailor. So I go to the market, pick out fabric, and actually the most recent ones, I'm like, can you just pick out something for me? I'm too busy.
But Danae will come to me and say, by the way, I told Jonathan that he can take off for the next 2 days.
Yeah, he's in charge of the schedule.
I have to figure out how to do pediatrics without
I'm like, he really needs to make my dresses. Anyways, yeah, it's a lot of fun. We're a small community around there. But we wanted to talk about having life more abundant, because this whole fistula program really reminds us of Jesus' time, and we have to think about, these are the outcasts for us in our village. I mean, there's many more people, but we have to think back on Jesus' time. Who are the outcasts then? So obviously lepers, and Olen talked a little bit about the woman with flow, the woman who had been bleeding for 12 years. Any other suggestions? Anyone out there?
Psych illness.
Yeah. Anyone else? Mm-hmm. Yeah. We were trying to come up with a list of them, but
Cripples.
We thought. So the verse that I have always liked, even before we went out into Chad, and is Matthew 9:35. And Jesus went about all the cities and villages, teaching in their synagogues and preaching the gospel of the kingdom and healing every sickness and every disease among the people. And if you just think about that, it is really just an amazing verse. Like, it really is amazing. And you can imagine if that were going on now. Whether we're able to heal our patients physically or not, we need to connect with them. We need to connect them with the source of abundant life. So many of the fistula patients we are able to heal, but there are those select few that you think about constantly. Why couldn't I fix that patient? So, we're not God. We can't do everything perfectly. We can't fix everything, but we can connect them with the source of abundant life, which is God, which is Jesus. Do you want to talk about your spiritual questionnaire?
Sure, yeah. I thought it was really cool when you read the verse about having life more abundant. Did you notice the baby started clapping for it? That was timing to a T. So what we did at one point, we made these spiritual questionnaires that we engage our nurses, our staff. We're excited to do these for patients that came to the hospital, especially the inpatients. And it was a half a page, and it was asking them, just a very simple spiritual questionnaire. Not trying to get into doctrine or theology or any of that, but what is your spiritual background? We're a 65% Muslim country, 35% Christian, 100% animist. But everybody knows what religion they're supposed to be, but nobody actually has a Quran, has a Bible, knows really what they say. They just know what religion they were told they were born into. And this was kind of just getting an idea of what patients came from a spiritual aspect and what they were open to. And a lot of those patients then would want to have prayer. They would say they would like somebody at the hospital to come pray with them. And I had a very good team of elders at our local church, and they spoke different languages of the surrounding area. So if I had a patient that came in and spoke one language, I would text Henri and have him come pray with him. If it was a different language, I'd text Pierre and have him come. And our church elders were very engaged in that process. And then at the end, there was another question at the end that said, would you like for us to follow up with you at your home, either with spiritual care or with medical care? And a lot of them would eagerly solicit having a nurse come visit them in their home. So we actually had 3 motorcycles that were donated to us for evangelism purposes. And we would have our nurses sign up in teams of 2. Usually 2 that spoke the same language. One would always have to be a nurse, and they might both be nurses, or one a nurse and one, I don't know, an accountant or whatever else the other one is. And they would go travel some pretty significant distances, maybe up to 40, 50 kilometers to go visit these patients at home after they went back. And then we tried to engage the pastors in those villages to then follow up with the patients once that patient was healed, and we kind of didn't really have a good medical excuse to go visit them anymore. And it was a challenge because, like I said, Chad is 3 times the size of California, and at one point, when we first got there, I think they had 5 or 6 ordained pastors for a country that size. So it was a challenge. Adventist pastors, yeah. It was a challenge getting lay members without a pastor there involved to go follow up in churches that weren't our local church. But that was kind of our goal. Uh-oh. We're in a time crunch. Anyways, it was exciting to find different ways that we could reach out. I know not all of these things may apply to a hospital-based practice in America, perhaps not even an office-based practice in America.
Basically, it comes down to you don't want to just be churning through the numbers. I actually do a lot of non-GYN cases as well, a lot of hernias, and they'll be in there for a day or 2. I know not in America, but in Chad we keep them for a day or 2. And it was like, what's the point of them? What is the point of them being here if we don't teach them about spiritual things? Like, what is the point? So it was like, what's the point if I churn out 7 surgeries today? It doesn't even matter. So we're trying to make something lasting and impactful that can change the system, but it's hard when you have to have the team on board. It's a lot of work to organize a team to get things done. So, we're trying to come up with new things.
Well, and I don't know, are there pastors here? No, okay. So a pastoral skill set is actually a little bit different from a chaplain skill set. We tend to overlap them, but they're not exactly a complete overlapping Venn diagram. So one of the things we wanted to do was to organize some chaplaincy training for our local pastors and for lay leadership, because when you only have a small number of pastors for a vast geographic area, really lay-led evangelism is what we really need to do.
So how can this relate to your practice? You might not have a different language than your patients. You probably speak the same language. You might be going on a mission trip, so the audio God pods and the picture Bibles might be something you should think about if you're going on a mission trip. You could create a questionnaire asking your patients, I don't know if you're clinic-based or hospital-based, just some ideas to think about. And the main message we wanted to kind of bring it down to is look for the outcasts, look for the marginalized, look for people that might be in church, or they might not feel like they can come to church, or they might not feel like they can talk to you about spiritual things because you're better than them, or they think that you think that, or it's not actually true. But look for them and try and find ways to connect with them, because it's all about connections, and it's all about making that connection. Get past the social stigmas, and prayer works. And actually, people want to be prayed for. Even they're busy, they put on a good smile, but people are yearning to be prayed for. So if we open those pathways and talk to them and ask them about it, most people will say yes. And I'm sorry, I don't think we have much time for questions.
We have time. We got like 10 minutes? 8 minutes? 7 minutes? Yeah.
What about pictures from your 2,000-mile hike?
That's actually to follow after this. Sorry,
You know,
Castle
we
Bonos,
did
we're
talk a
getting
lot about death, and it actually is true. It was a way, an outlet to kind of heal. So I recommend it for everybody. Everybody's stressed. I think you should take a sabbatical, take 9 months off, and go hiking.
Any other questions? Yeah.
Yeah, I mean, by the way, well done presentation, and what a very meaningful work you have to do in terms of restoring women. I'm family medicine, lifestyle medicine. For me, it's man, how do you make your surgery less necessary? And I think about the upstream effects. I mean, so it's completely traumatic birth that lead to these fistulas.
Mm-hmm.
Is that what you have to work on? And how big is that problem? How easy is that to solve?
That's a really interesting question. It's been our life dream for 12 years. We've been over there working in Chad, and it's hard to leave.
I have a passion for public health. I have a passion for other people doing public health. And the prevention side of things is where it's at, right? I mean, that's what really all of us, all medicine should be, is focused on preventive stuff, public health. We've been fortunate to have a relationship with Loma Linda. We've had several MPH, Masters in Public Health, that have finished, and as soon as they finish, they come out to us for, one stayed for 4 years. And that's been amazing, because they'll go to all of the neighborhoods in our town of 60,000 people, and eventually reach out to all of the villages in our district of 200,000 people, giving week-long or 2-week series on public health, from HIV, TB, hand hygiene, toilet hygiene, dental hygiene, just going down the list of things, including there has been a strong initiative to train the traditional birth attendants. And these are people that don't speak French, aren't literate, they only speak their local language, and they can only deal with picture handouts that we give them. But we try to have these active training sessions, which hasn't happened in a while.
I have lots of ideas. It's just implementing that into a bigger picture. It's hard. One way is, another country was using cell phones, and when the woman is in labor, they can text you, and a motorcycle can go out to their village. I also want to get early ultrasound everybody for free, and if they can get a due date, then I can induce them at 39 weeks and prevent them from getting stuck at a village where the roads are blocked because they live in a flooded area during rainy season. They're blocked. They just have to deliver out, and they can't get to the hospital. That's just the tip of the iceberg, but there's so much that pretty much anything you do will help. So it's just a matter of getting people to help and figuring out how to implement that.
I mean, the public health, the preventative stuff isn't really our specialty, but we are very passionate about it. Next door in Cameroon, ADRA actually got a grant. It was 10, 12 years ago. They got this grant. They bought a Land Cruiser. They went from house to house in the surrounding villages, doing ultrasounds, getting due dates, getting GPS coordinates and phone numbers from all those pregnant women. And when they got a phone call from that from that phone number, they knew their coordinates, and they could send out the Land Cruiser to get the patient and bring them to the hospital as soon as they went into labor. That's not without financial investment.
I think we should just induce everyone, but.
Yeah, it is something that we need to do, and one of our goals is actually to have a surgical training program and a family practice training program. Because right now what Chad has is a lot of general practitioners, and this is not against general practitioners at all. But if we could get people formal training, if we get a formal surgical and family medicine programs there to train physicians, we could prevent a lot of this, or at least have good surgical care.
And this is just the tip. I mean, fistulas are like less than 1% of what we do in Chad. We do a lot of other things.
I was doing the math. That's not true. How many do you do a year?
I'm pretty
it's
sure
like
it's
5
less
or
than
6%.
1%. No, it's not very much. It is very rewarding, and it is why when I go back from vacation every year, I look forward to seeing those women, because I know I can make a difference. But it's less. I mean, we do a lot of other things too, and we appreciate all specialties and all help in medical.
Less than 1% would be less than 14 a year.
Anyways.
Yeah, that's right. All right.
He loves spreadsheets and math, so I have a hard time arguing.
You had mentioned that you were seeing a lot of fetal demise.
Mm-hmm.
Besides, the delay in care and, maybe the delivery
Yeah.
There's really no prenatal care. So when I took my boards a few years ago, my oral boards, I had to write things down, and I just have no labs. It's basically no prenatal care. I mean, they say they're doing prenatal care, but out in the health centers, they're not even doing blood pressure checks. So I'll have people come in seizing because there's just no prevention. And what we do in America matters. The preventative stuff that we do is saving lives, and everybody complains about this country, but it is so different than other parts of the world.
Also, malaria and general poor nutrition is
A lot of anemia because of malaria.
Yeah, I mean, how often do you see hemoglobin less than 4
I
in
figure
a pregnant woman?
there's a lot of things that kill the mothers. One is malaria. They die of anemia or just straight malaria. Their liver goes bad. I can't speak medical terms too, but I'm just used to...
The liver goes bad.
The liver goes bad.
You'll have to ask what the billing code is for the liver went bad.
This is why I can't practice in America. We're going to have to stay in Chad forever. I also had a hard time with oral boards.
They're yellow.
Anyways, so malaria, diseases of hypertension in pregnancy. We see eclampsia so many times, so seizing in pregnancy, and also hemorrhaging. Women die of hemorrhaging. And those things all of those things are preventable.
Just to give you an idea, our neighboring hospital 12 miles down the road is the regional hospital. Officially, we're supposed to refer patients to them. They have multiple times we've received women coming from their hospital in a private car who had a C-section, but were referred to us with an open uterus and an open abdomen. And the surgeon who began this, and I'm thinking of at least 2 cases, both of them were started for a dead baby. It was written down, diagnosed, the baby is dead, and they still went ahead with a C-section and then had to refer us the patient with open abdomen.
The GYNs in the room know it's just a C-section, though. So.
It's just a C-section.
I'm just kidding. Everybody likes to say it's just a C-section, but in Chad especially, I mean, it's just so complicated all the time. I'm scared even as a GYN, and it's complicated. Yes?
Do they even have a midwifery program in the country?
Yes. So when you go to nursing school, you can
Not really.
You can decide if you want to go into the midwifery track or the general nursing track. And if you are a female, you get the midwifery diploma, and if you get a male, you get the general diploma, and you really did exactly the same thing.
It's basically experience, and as you know, you'll take an experienced nurse over one who's not necessarily. I shouldn't say that. I'm going to get myself into trouble. But a lot of obstetric is experience, and so they learn on the job. The same with general practitioners who graduate in Chad; they learn on the job as well.
Well, we've had some very fresh medical school graduates who have come to us in Chad, and we're like, all right, well, I want you to spend a day or 2 with the midwife, learn everything you can with them about normal obstetric delivery, and then we'll get into the complicated stuff. And they refuse. They say, we could never learn from a midwife. As somebody who just finished medical school with really no obstetrical training. It's a challenge.
But I would love to start one. We have a nursing school that we actually started in Béré, and we would love to do a tract. We haven't gotten that far yet. We'd love to just add on a year or 2 to do it, to make it a midwifery program. It's just, another one of those dreams that we need more people to help.
We've graduated female nurses, so they are midwives, but they don't actually have any midwifery training beyond their male counterparts.
Any other questions? I don't want to make us late to the next presentation.
Doing a fellowship for the family practice that work in that country on how to better do their obstetrical care?
Yeah, so first we need an actual family practice residency.
There aren't any.
So there's no family practice residency in the country.
Yeah, we could. We want to.
We would love to, and we actually had 3 American-trained, and again, I'm a very American-centric person mindset, but we had 3 American-trained family practitioners, and we were really excited about starting a family medicine program. But life circumstances have happened, and one is gone, and another one is soon leaving. And the one who's left is running the whole show. There's no way she has time for that.
Every time we think we're set up to do a new outreach or a new program, then the team falls apart a little bit, and then you have to rebuild. And
the team doesn't fall apart. I mean, life happens, and
yeah,
folks have to return to America for very good reasons, or folks that were planning to come have very good reasons that they can't.
We don't judge anybody for not coming, or
we judge everybody.
No,
Y'all should be in
not
chat.
publicly. Not publicly. We don't, but I mean, this is getting into a whole nother topic, but we have children. It's very hard to raise your children in Chad. They can die of malaria. All of our kids have had malaria multiple times. It's a difficult place to live just from the fact of having kids, let alone yourself. Like, it takes 2 hours to cook a meal. You can't just open up something and eat it. It's a difficult place to live. So, you know, it's not for everybody, but...
Our generator won't support a microwave, so everything has to be cooked from scratch.
There, back in the 50s after World War II, White Memorial in Olen did have a course for family docs that were going in mission service. And they gave them about 6 months of OB and surgical training, a simplified midline incision, and they could do what most things urgent that need to be done. That is not available, but it sounds like it
Yeah.
could be
They-
worthwhile.
They do have a fellowship for family practice, an OB fellowship, where they spend a year doing
It's
C-sections.
a cesarean fellowship,
Um,
yeah. And Loma Linda, Carl, how long ago? They started a global surgery fellowship for those going overseas. You get like a month in ortho, a month in uro, a month in what I don't. Okay. Yeah. But yeah, you have to complete a surgery residency before you can get to that fellowship.
But we love the discussion. It's great.
No, surgical care is a huge need. I mean, there's lots of needs.
I think we need to wrap up, right?
I think we need to wrap up, yeah.
Sorry, we went over.
All right, let's have a prayer, and then we'll carry on with our activities. Dear God, thank you again for the chance to commune together. Thank you for all that you give to us. Thank you for the things that we learn. Help our focus to always be on you. Today, tomorrow on the Sabbath, and throughout our lives as we interact with family, with friends, with community, and with patients. Please forgive us for our sins and help us to keep you as the focus and center of all we do. Amen.